Okay, thanks for the invitation to this conference, and I heard some very skeptical views about clinical practice guidelines. Do we need them anymore, and are they implemented at all? Did they show any benefit? And I would like to take, of course, sort of an optimistic view, and I declare my conflict of interest because I'm the chair of the Guidelines International Network. I need to speak pro domo. But on the other hand, I can assure you that I don't have any other conflicts of interest, especially no ties to the industry or to insurers or anybody else. So the Guidelines International Network was indeed founded in 2002 from the background that we all saw rapid increase in publications of guidelines, and there was a perceived inflation uncertainty about validity, duplication of efforts at that time. So 13 years ago, we saw the problem, and this is why the Guideline Network was founded. And our mission is to lead, strengthen, and support collaboration in guideline development, adaptation, and implementation. And you will see these orange marks here that organizations are spread all around the world. We are now spanning 6 continents, 52 countries, and we comprise 109 organizational members, not only organizations that develop guidelines, but we are also partnering with the Cochrane Collaboration, HTA Institutes, INATA, to just try to network with those who initiate quality improvement initiatives. And we also have some individual members. We have a regional committee in the United States, we have a regional committee in Northern Europe, and in Australia, New Zealand. And the idea really is to learn from each other and work for improvement. So coming back to my question from the beginning, can guidelines protect from overdiagnosis? I would answer like Radio Yerevan. In principle, yes. You only need to mind the steps. And the steps where you could stumble are, of course, the topic chosen. It might be much more difficult to convene a guideline group that is multidisciplinary to come to a conclusion about HRT than from any other conditions like appendicitis. So that's the first thing you need to consider. And then, of course, the methodology applied. You would stumble over the guideline content, and it won't be implemented if the methodology is not sound or not reported and the guideline is not trustworthy. It also depends on the healthcare system and the target users addressed. If you come to a healthcare system and that I might report my PTSD in this area as well, I remember a conference of gynecologists back in 2003, and the Ministry of Health in Germany told us, whatever you say, I will introduce mammography screening. And the scientific community said, no, our idea was to regularly invite the women to a decision talk. And then, after informed decision making, she would decide to go to screening or not. And she said, no, I won't do that because it's a political interest. So you have difficulties with the healthcare system, and of course you have difficulties with financial incentives. And you have interests of the government as well as the healthcare providers. And you also have, of course, the problems on the individual level. These barriers have been reported, and I will come back to this later. And it depends on, are there any structures in place to network with? Or are you just throwing and disseminating your guideline into an off? Or do you have mechanisms in place like a quality initiative for performance measures or disease management programs where you can really implement the guideline and promote its application? So what is the status quo? Guidelines are intended to promote appropriate healthcare. That means they should address not only underuse, but also overuse and misuse. This is what we are coming from. But okay, we need to be aware that in many areas, guidelines do not achieve their intended goals, especially when it comes to the formulation and trying to implement negative recommendations to prevent overdiagnosis and overtreatment. And I want to show you some very, very hot off the press evidence confirming this. We have seen a slow uptake of new research findings from guideline groups, especially when it comes to taking away something from people. A specialist bias has been discussed, so that if you don't have opposition in a guideline development group and you only have one specialty, it's hard for them to give something away. And this is from a psychological point of view associated with loss aversion, a very natural and human thing. And you have peer pressure. It's hard to implement something if you are young and a young scientist, even if you have the knowledge, if you have these alpha people in place, it would be hard to argue against them. And we do know, since Jeremy Grimshaw's systematic review about guideline implementation back in 2004, that there are multiple barriers. My question is, don't you think that these barriers and problems would apply also if we implement a single recommendation, like in a Choosing Wisely program? We don't know. In the guideline world, we need to make this hard experience. And what is the worst thing we need to face? It's psychology. And it has been formulated by Francis Bacon in 1645. It's just the fact that human understanding draws everything else to be in harmony with and to support those things which once pleased it. And though it must be admitted that the force and the number of instances that occur to the contrary is greater, it either does not heed them, or it distances itself from them, and that just without any prejudice, just so that the authority of those previous beliefs remains inviolate. And this idea led to the theory of cognitive dissonance, where social psychologists say this is the most stable theory psychologists have ever invented and empirically tested. And we need to be aware that attitudes once adopted and decisions once made are extremely resistant against change. And this applies when we address knowledge transfer. It applies as well when we try to change attitudes and behavior. So this is the biggest barrier. What are the potentials? There's something we might be able to do about it. One potential is that now we have international consensus about guideline methodology. And this was one of the efforts of the Guidelines International Network. I will show you what this means on the next slide. We do have the AGREE instrument to assess the quality of guidelines. We have the IOM reports on clinical guideline development. We have a Guideline International Network position paper defining 12 standards good guidelines should meet. We have implementation research, which is a vastly growing field of research, and this is strongly aligned with social psychology, providing us with the theories and targeted interventions to do the best to change behavior. And we have opportunities for networking with other quality improvement initiatives. And we do have open access to methodology support. Every guideline development group who would like to perform better is invited to visit this website, the Ginn McMaster Guideline Development Checklist, which is a big manual supporting these groups. The potentials. I would like to invite you to a short excursion of the German guideline system because this is where I can present some data. In Germany, we have the special situation in contrast to Great Britain, but just as like as in the US, that ownership and responsibility for guideline development lie with the profession. It's professionally owned. Guidelines are developed by scientific medical societies. You say, so far, so bad. But in Germany, the difference is support, coordination, and quality assurance are provided by a national umbrella organization. And this is the Association of the Scientific Medical Societies, where we currently have 171 members. And we have just opened up for allied health. Midwifery Society has just joined this, and I think this is important to open up for different and competing views. AWMF strives for networking with other national quality initiatives, like with the quality performance development, quality measures performance development, disease management programs, which are in the social code book, which are regulated by the social code book, and AWMF is a founder member of Ginn. So what do we have regarding quality assurance? We do have a guideline register, just as ARC has. This usually contains around about 700 guidelines at As per now, it's 753. All of these are developed by groups around the scientific medical societies, and we have implemented minimal inclusion criteria so that every guideline is assessed by 2 independent reviewers. And this starts with public announcement of guideline projects under development. We receive a short project plan, we review it, and we look that interdisciplinarity is there in place and the stakeholders are involved, and we do look if that topic of the guideline has been addressed before. And if this is the case, we say, look, go and cooperate with this other group to avoid contradictory results. And we require the existence of a guideline report describing methodology and ensure transparency of the process. We require that declaration and management of conflicts of interest is documented. We require up-to-datedness, and AWMF will delete guidelines that are older than 5 years and nobody is working on them. If a group says, my guideline is still valid, I've checked that, that's fine. But if there's no checking, it will be deleted. And this is always supported by some guidance, and this guidance has a manual area to support guideline development groups. This is the quality management perspective we have. Go and try to get better. We also provide support and do outreach visits, but we also implemented these rules. And this was widely accepted, and I just can say thank you to around about 2,000 guideline developers in Germany who do all this on an honorary basis and accepted year by year some more rules and implemented them. So, yes, we can. What is in the register? And what can we do for quality improvement of our guidelines to make them trustworthy? In Germany, we can say declaration of conflicts of interest is a fully implemented standard. Of the 753 guidelines published as per November 2014, 61% are not developed by a single society alone. And the range of organizations, societies involved is 2 to 56. And also, more than 100 self-help patient, I would like to say citizen organizations have also been involved. And more than 70 organizations from the allied health sector. 17.4%, that means 131 guidelines, meet the agree criteria regarding as well as systematic review of the literature. That means search, the selection, appraisal, evidence table, everything, at least for some key questions. And they applied formal consensus techniques, not informal group discussions, which is something totally different, with involvement of all relevant stakeholders. At least 24.2%, that means 182 documents, meet the criteria of at least one of these 2 areas. So that's something, I think. And do we have negative recommendations at all? We looked for that in a sample of guidelines meeting these top criteria of being systematic developed published in 2006 and 2013. And this sample of 40 showed that 37 of these guidelines do provide negative recommendations. The percentages of negative recommendations in a specific guideline as compared to all recommendations ranges from 1.2 to 63.2. Of course, the top 2 regarding negative recommendations are hormone therapy and unspecific low back pain. The amount of negative recommendations, this is what we found, is not dependent on a society and specialty because we have these multidisciplinary groups. It is dependent on the topic addressed and if there is a need for negative recommendation. Can we reduce overdiagnosis? Do we have data from that? And this is when it comes to networking. Networking means that we cooperate with the external quality assurance according to the social code book, paragraph 173A. And I want to invite you to detect the error on this slide. When it comes to reducing axillary interventions in DCIS. Something wrong here. It needs to be less than 5%. We wanted to reduce axillary, so this is my mistake here. So we needed to reduce the interventions for women who just don't have cancer or don't have any risk. And we do see after implementation of these quality measures directly derived from a negative guideline recommendation implemented in 933 hospitals who serve for these patients, and in 21,000 cases in 2011, in 2012, we just are almost at zero. And in the following years, I do have the numbers from 2012 and 13. It's just about the same. So I think there's an improvement, a potential for improvement that we have just met. Yes, we can. What should we do to implement guidelines better? And I'm very much interested in these Choosing Wisely campaigns because I do believe that we need to address the public with these negative recommendations, maybe also with positive recommendations where we see an underuse in the system. We heard about that in the cancer talks earlier. And we need to find new formats for transporting the information better. But when we discussed this in Germany, there was some concern about the evidence-based and the trustworthiness of Choosing Wisely recommendations that are published currently. And upstairs you will see a poster just confirming this. If only 2% of the existing Choosing Wisely recommendations are based on a systematic review of the literature, I don't know if we do more good than harm if we implement them. So in Germany, we discussed to have some guidance as for the guideline development to assist developers of Choosing Wisely recommendations to create trustworthy recommendations. And we decided to address also over-under misuse in areas where guidelines are not adequately implemented or missing. If you have a methodologically excellent guideline in place, you are fine, you can derive your recommendations from there. Otherwise, you need to do a systematic review because we thought a good recommendation should meet the following criteria. Clarity of the recommendation, it should be specific. It makes no sense to say no imaging in low back pain. This is just wrong. If a patient has red flags, you would immediately have an MRI. You have to, there must be some indications for under and over and misuse. So there needs to be an improvement potential. Don't intervene if there is no potential for improvement. We should look at the quality of evidence supporting the recommendation. We should also look at the strength of a recommendation where it comes to balancing potential benefits and harms. We should look, is the topic influenceable at all? We should look at the implementability and need to address barriers and facilitators. And we should be aware that here is a risk of unintended consequences associated with implementation. For example, if insurers just take it up and say, okay, you're not supported for this anymore. My outlook would be, after having seen so many excellent initiatives here and having attended shared decision-making conferences, having attended the Cochrane colloquia, having worked together with evidence-based healthcare initiatives, with INATA, having worked with the Performance Measures Working Group at the Guidelines International Network, having seen the work of the Preventing Overdiagnosis group, I presented the paper of them yesterday, how could we define diseases, and the Choosing Wisely initiatives, this conference to prevent overdiagnosis, and the guideline community, we should work together. If we as the profession, together with consumer citizen representatives, are not speaking with one tongue, it would be more than easy for any government and any insurer to dispart us. So my dream and my conclusion would be, there is justified criticism of existing guidelines, but this should not lead us to discard the concept of guidelines. CPG recommendations might still be the best, but not the only instrument we have to promote changes on the individual and system level. Any quality improvement initiative will need manuals and rules to ensure transparency and trustworthiness. And my dream is a concerted action to improve appropriateness of healthcare as a joint effort of current initiatives. That's just a dream.